This is a video shared by Dr. Kayat from São Paulo, Brazil. This patient presents with progressive worsening of visual acuity, associated with diffuse vitreomacular traction. Preoperative OCT examination reveals areas of macular schisis and vitreous traction in the foveal region. Pars plana vitrectomy was indicated for the treatment of the maculopathy. At the beginning of the surgery, the surgeon uses direct visualization through the microscope to perform the vitrectomy in the region posterior to the intraocular lens, removing the anterior hyalloide. After the core vitrectomy, he injects a small amount of intravitreal triancinolona to stain the posterior hyalloid membrane, which is diffusely adherent to the macular region. Using a membrane pick instrument, the surgeon makes small openings in the posterior hyalloid around the foveal region. Note that he makes centripetal movements to perform these openings, aiming to isolate the parafoveal hyalloid from the peripheral posterior hyalloid, and takes great care to avoid generating traction on the fovea and consequently creating an iatrogenic macular hole with his maneuvers. Next, he uses the vitrector probe with low vacuum settings and performs circumferential trimming in order to separate the posterior hyalloid from the foveal region and the periphery. Patients with vitreomacular traction syndrome exhibit abnormal vitreoretinal adhesion, and therefore, when performing maneuvers to detach the posterior hyalloid, it is also necessary to be very careful not to cause iatrogenic tears in the peripheral retina. Brilliant blue dye is then used to stain the internal limiting membrane. The surgeon uses an opening in the ILM in the inferior nasal region to start peeling. He performs a fovea-sparing ILM peeling technique, peeling the internal limiting membrane 360 degrees and leaving it still adhered to the parafoveal region. At the end, he uses the vitrectomy system probe to trim the internal limiting membrane. Since there were no iatrogenic breaks in this surgery, it was not necessary to use tamponade agents after the fluid-air exchange. The patient showed improvement in visual acuity postoperatively, and the postoperative OCT examination shows significant anatomical improvement in the macular region,